Hello, and thank you for the opportunity to speak here today. The presentation is titled A Leak and a Plug or Two. I have no actual or potential conflict of interest in relation to this presentation. Post-surgical paravalvular leak is defined as an abnormal communication between the sewing ring of a surgical prosthesis and the native annulus. This is seen clearly on the gross anatomical image, with multiple PVLs identified by the white indicators. Incidence of post-surgical PVLs varies based on the location. PVLs in the aortic region have an incidence of 2 to 10%, and PVLs in the mitral position have an incidence of 7 to 17%. The mechanism of PVL can be stratified in a temporal fashion, with early PVLs most commonly related to a technical issue at the time of surgery, and late PVLs typically developing secondary to suture dehiscence related to endocarditis or annular calcium resorption. With increased attention in the diagnosis of PVL of surgical valve prosthesis, standardizing research became necessary, and thus the Paravalvular Academic Research Consortium was formed, with meetings in 2015 and publication in 2017, attempting to highlight the appropriate assessment and proposed clinical endpoints for future clinical trials. Beyond the scope of this committee was therapeutic options for PVL, specifically surgical versus percutaneous therapies, and thus made a recommendation to proceed to PVL closure if suitable. With that, several studies have retrospectively reviewed outcomes in patients with transcatheter therapies versus surgical therapies. Here, 381 patients at Mayo Clinic from 1995 to 2015 who underwent PVL intervention, 195 in the percutaneous group and 185 in the surgical group, showed that there was a slightly higher rate of reintervention in the percutaneous group, with no difference in survival at 5 years. Following up, 231 patients from 94 to 2014 underwent PVL intervention in a separate study, of which 80 were in the percutaneous group and 151 were in the surgical group. Here, surgery was associated with survival benefit with a hazard ratio of 0.28. Going further, 114 patients from 2007 to 2016 underwent PVL intervention in a separate study and showed that there was no difference in survival at 1 year. With that being said, if percutaneous therapy is to be undertaken, it should be done in experienced centers. This graphic shows the need for subsequent surgical treatment following percutaneous PVL closure, and shows that the need for intervention drops off dramatically after 130 cases. In experienced centers, comfort with multiple approaches is mandatory. Routes of therapy will be based on the position of the PVL. In aortic PVLs, a retrograde transaortic approach is preferred to a transapical, which is preferred over a transeptal approach. In mitral PVLs, an antegrade transeptal approach is preferred to a transapical, which is preferred over a retrograde transaortic route. Now, moving on to our case, we recently evaluated a 69-year-old female who was referred from an outside institution with a chief complaint of fatigue, weight loss, orthopnea, and transfusion-dependent anemia, all of which began about 6 months after having an MVR with a 25mm mosaic porcine valve implant. The patient was found to have profound hemolytic anemia and had undergone extensive evaluation for an oncologic etiology, delaying diagnosis of severe PVL of the bioprosthetic mitral valve until a TE was performed, showing eccentric PVL at the 6 to 8 o'clock position as marked by the white arrow on the TE images on the top, with a maximal dimension of 14 by 3.4 millimeters from the ventricular and atrial aspect as measured by multi-phase CT, seen in the images below. Initially, transeptal access was gained and the soft glide wire and angle catheter were used to cross the PVL. The wire was passed through the PVL and looped in the left ventricle and into this descending aorta to create a rail for stability. The TorqueView delivery sheath was advanced into the descending aorta. However, on pullback with the AVP2 devices in place, there was unacceptable instability of the delivery system, and thus the antegrade transeptal approach was aborted. Having planned for alternative access prior to intervention, the case was converted to transapical access for better stability of the catheter system. Co-registration of the CT images with fluoroscopy were performed, and CT fusion was used to guide safe transapical access. The correct rib space and angle of approach were identified so as to avoid lung and distal coronary arteries. A micropuncture catheter was then advanced over the wire and into the left atrium after confirming adequate position by TE. The wire was then exchanged for a 260 centimeter glide wire, which was snared through the transeptal sheath and exteriorized out into the right femoral vein, creating an AV rail. At this point, a torque view delivery catheter was advanced from the femoral vein in an antegrade fashion across the PVL, and an 8 and 10 mm AVP2 device was deployed. Due to persistent leak, an additional 8 mm AVP4 device was advanced and deployed across the PVL. Transapical access was closed using an AVP4 device and Surgiflow hemostatic matrix. Residual PVL was evaluated by 2D and 3D TE and determined to be trace. In summary, the case highlights the primary message of the PVL ARC back in 2017, and that you must make the diagnosis to avoid delay in appropriate therapy. You must have appropriate pre-procedural planning so as to be prepared for a primary and secondary approach to PVL closure. And finally, and most importantly, know when to stop and engage alternative strategies early to prevent avoidable morbidity. Thank you for your time.